This is the Cardio Ohio podcast, a presentation of the Ohio chapter of the American College of Cardiology. This is Kanny Grewal, president of the Ohio chapter and host for today's discussion. Further information about this podcast, including speaker biographies as well as references, are available at Ohio-ACC.org, where you can also provide feedback and suggestions for future topics. The podcast will also be available for download wherever you access podcasts, and we encourage you to subscribe to receive updates on future sessions. I'd like to welcome everyone to episode 3 of the Cardio Ohio podcast. Thank you for joining us today. Today, we're going to talk about a few key topics in the field of sports cardiology, which is a growing area within cardiovascular disease. I'm really happy to have two experts from here in Ohio joining me for today's discussion. First, from Cleveland, I'd like to welcome Dr. Mike Emery. Many of you who had an interest in the area of sports cardiology are very familiar with Dr. Emery's work. He's currently the co-director of the Sports Cardiology Center at the Cleveland Clinic. He was previously at Indiana University. He's been very active in the Sports Cardiology Council at ACC, and he's spoken at many of our events in the past years. Mike, welcome to our discussion.
Great to be here. Thanks for having me.
I'd also like to welcome Dr. Simon Lee from here in Columbus. He is a pediatric cardiologist at Nationwide Children's Hospital. He's a specialist in advanced cardiac imaging in pediatrics as well. And my understanding is he's the program director of their current program for coronary anomalies as well as Kawasaki's disease. Simon, thanks for joining us.
Yep, excited to be here. Thanks for inviting me.
So we're going to, over about 30 minutes, just hit a touch on a few key topics in sports cardiology that I think are of interest to our audience of general cardiologists, advanced practice providers. We even have some fellows in training joining us as well in this program. I'd like to start by addressing the post-COVID patient, because even though case numbers have been dropping, which is excellent news finally after 2 years of our pandemic, many of us who are in sports cardiology and adult cardiology have been, of course, dealing with quite a few patients who have recovered from infections or maybe having ongoing symptoms post-COVID. And there's been some controversy as we've learned about the incidence of cardiovascular anomalies in this group of patients. There's been controversies about the extent of testing needed. So I thought we could start with that. Recently, the ACC did put out a consensus statement, post-COVID cardiovascular sequelae, and I'd really encourage everyone listening to check that out. It's a very nice document that's very practical, and it covers really the current knowledge base we have about all of the various cardiovascular manifestations during and after COVID infection. But since we're talking mostly about young patients today in sports cardiology, Mike, I thought I'd just ask you, obviously you see a lot of these patients, we all do right now. Initially, there was a lot of interest in doing extensive testing, maybe even MRIs in many of these patients, but would you agree with the consensus document that really for asymptomatic COVID positive patients, or those even with mild symptoms, that our approach now should be to try to selectively and judiciously use testing in just a minority of these?
Yeah, I would completely agree with that based upon our current level of knowledge. I was just sitting here reflecting on the pandemic and realizing that it was just in May of 2020, so not even 2 years ago, that the ACC Sports and Exercise Council put out their first statement about return to play, really at the beginning of the pandemic. And it stemmed from really just the hospitalized patients. So we're not even talking athletes or asymptomatic or mildly symptomatic, really floridly symptomatic hospitalized patients, and the initial concern about cardiac involvement. And since we knew little about COVID and its sequelae and its consequences at the time, we had urged, caution. And then as that time has gone, and it's amazing to see what had happened in just a little over a year, how much data was collected by really having great communication and great teamwork across multiple institutions to come to a point where now we have several thousand athletes screened, evaluated, and really coming to the conclusion that, at least in this population, the incidence of myocarditis from COVID-19 is not nearly as high as we were fearful of in the past. Now we need to sort of regain our footing and understand, probably back off on a lot of the screening that had been recommended in the past and had been done across even major collegiate institutions.
So given that situation, when in terms of symptoms that you hear about in a patient who either has current or recent COVID infection, what symptoms or other clinical parameters in either a young patient or athlete would warrant you to consider some of the basic testing like EKG, echo, or troponin levels?
So that triad testing is what it's called these days, is really reserved now based upon our current level for those with moderate to severe symptoms of their initial infection, or they had specific or concerning cardiopulmonary symptoms, meaning a concerning chest pain, not just, chest pain that strikes in the zone from your knees to the top of your head, but concerning chest discomfort, excessive dyspnea on exertion, syncope, palpitations, all those symptoms that would concern us whether you had COVID or not. So that's a good place to start with setting up the triad testing, the troponin level, an ECG, an echocardiogram, and then additional testing on top of that, most notably cardiac MRI. If one of those tests becomes abnormal, or they continue to have these concerning cardiopulmonary symptoms despite that a normal potential triad testing.
Great. So, Simon, would you agree then that CVMR, obviously you and your group here in Columbus were involved in some of the early data on myocarditis in athletes with MR imaging, but do you agree now that we've learned more about the incidence and so forth that MR should be more judiciously used?
Yeah, no, I definitely agree with how the guidelines have sort of evolved over time. And one of the big contributors to that, I think, is just how many patients we've all seen for clearance, how many people were referred. And a lot of centers, including our own at Nationwide Children's, we were really trying to keep a select number of physicians seeing these patients to develop a little bit of familiarity and expertise. And the other thing too is, I think, just seeing, emphasizing this gradual return to play, which everyone in Ohio, at least in the high school athletes, their trainers, everyone has been really on board with that. And while the triad testing is important, I think that's really been a big key for identifying kids or older athletes who may have some concern, who may have a concern for some cardiovascular involvement. You have them kind of ramp up gradually, increase their activity. And then if some symptoms develop, I mean, that's kind of been the bigger red flag from my standpoint, at least for the adolescent and high school athletes.
Yeah, I think emphasizing the graded return to activity is very important. I'm the team cardiologist for the Columbus Crew, and I work with our sports medicine team here in Ohio Health, where there's a lot of high school trainers involved. And I think I've seen that they've gotten on board with that concept as well, that there should be a graded return using the trainer or maybe the team physician, if there is one, as to help monitor that return activity. And by doing that, I think most kids really do get back to full activity pretty quickly. One other question for you, Simon, is, obviously in your experience in pediatric cardiology, you see a lot of pericarditis in the younger population. Here at Riverside, we use high sensitivity troponin. We have for a couple of years now. And to me, it's pretty impressive how many patients with either COVID infection, especially in the hospital, of course, who are hospitalized, or even other viral syndromes, will have mild troponin elevations. But do you consider that synonymous with myocarditis, or should we be relying on additional imaging before we just make that diagnosis based on a troponin level alone?
Yeah, I think that's a really interesting question, because one of the other things that's really evolved during the pandemic has been how we diagnose myocarditis, and just seeing that there is this spectrum of, referencing those guidelines that were just published, or that expert consensus document, I should say, they actually lay out, this is probable myocarditis, possible, and definite myocarditis. And in cases like you're talking about, where you do have a little bit of troponin leak, and again, I think high sensitivity troponin is sort of another area where, we're talking of tests that wasn't really developed to look for this. And so, how do we interpret that, or how do we utilize that information? and make a diagnosis for myocarditis or perimyocarditis or something like that. But yeah, I think that's the other interesting thing that's come out of this is just this spectrum of sort of cardiovascular involvement after infection. And so on our end, we don't use a high sensitivity troponin. We use just the regular troponin.
Yeah, the high sensitivity troponin has been interesting in our institution as well. Like any test, it has to be taken in context of the clinical scenario for which it's drawn from. And when we look at high sensitivity troponins in particular, things can acutely elevate that, such as exercise. Acute exercise, especially high intensity exercise, can slightly elevate that high sensitivity troponin. So when you look at the guidelines, and we were talking about when to measure troponins, and people would recommend, exercise cessation for at least 24 hours prior to that. Things that, makes a difference, how your lab sets that normal and abnormal level. When you look at the actual 99th percentile recommended by the manufacturer for most high sensitivity troponins, they have different numbers for men and women. So you have to take a lot of this into context. And I've noticed the same thing. A high sensitivity pops back sort of like gray zone, mildly abnormal. Yet the regular troponin T is 100% normal, SED rate is normal, CRP is normal. And then I start to take those tests in a little bit more of a different vein than if other things are abnormal with it.
And just to follow up on that, Mike, when obviously only a minority of these COVID positive athletes are going to end up with a true clinical myocarditis. But when you do see that, that's a pretty high risk situation, right? In terms of return to play, and they do need a longer a period of athletic avoidance if they have a true, clinical myocarditis.
Yeah, we definitely believe that, acute myocarditis increases your risk of sudden cardiac arrest and sudden cardiac death, right? That's the most fearsome abnormality we're trying to prevent. That sort of ongoing inflammation in a setting of high intensity and that high adrenergic state is certainly a cause of concern. There are athletes, however, that have mild case of myocarditis that ignore it and do fine. So we're trying to find the needle in the haystack. But certainly if you've been identified with acute myocarditis, current guidelines is a restriction for 3 to 6 months, depending upon how severe that initial case is and how soon you recover.
Well, thank you. I think obviously our understanding of cardiovascular manifestations and complications of COVID is probably going to continue evolving. Hopefully this is not a topic we have to keep revisiting because of the clinical volume, but we've also learned not to really expect anything with this pandemic that we can count on. I do want to get into a few other topics related to athletes and young patients since we have both of you here. So Mike, I know you run the sports cardiology center there. You obviously see a lot of symptomatic athletes, probably both high school, college, and young adults as well, and you, Simon, as well. I think I do notice that amongst general cardiologists, sometimes there's a level of kind of trepidation when a teenager comes in with symptoms in terms of who needs testing, who needs to restrict sports. Of course, there's always such an urgency with young athletes because their coaches, parents, and the athletes themselves want to get back to activity right away. So, Mike, in terms of symptoms like syncope or lightheadedness, when you see a young athlete who presents with dizziness, syncope, or even just lightheadedness, what are some of the historical features that might give you some clues as to when it may be a benign cause versus a potentially more structural cause that warrants investigation?
Yeah, this is a pretty common referral to us in sports cardiology. And I think part of that is that as you said, there's a fear there that they don't want to miss something. But when you talk about syncope, lightheadedness, dizziness, palpitations, just like in any patient, the history is the key here. It may be even more prominent in a young athlete. When do you get syncope and lightheaded, and what do you mean by that? So for instance, particularly in endurance sports, there's a phenomenon called exercise-associated collapse. Sounds ominous, it's actually benign. So that's an important and key part of that history associated with sudden collapse at the end of a race. And not as you're sort of crossing the finish line, but you cross the finish line, and you stop suddenly and you collapse. So you have to be careful and take that history very thoroughly, because that's considered exercise-associated collapse, which is really the loss of the muscle pump from sudden cessation of activity. So as you're running, your muscles contracting against your veins in your legs provides a big chunk of that that venous return back up to your heart so you can get to your brain. And when you stop suddenly and you lose that muscle pump, you lose that venous return to your heart and hence flow to your brain, and you have sudden collapse. That should be very easily ascertained from a history and really doesn't need any further workup as long as you've taken the history correctly. So this is such a big deal that for those of you who run marathons, half marathons, 5Ks, when you get to the finish line, you don't just get to stop at the finish line and get your medal, your water, and your banana. You got to walk through the chute, right? And at the end of that chute is where you'll start to get your water, and then you get your medal, and then you get your banana. So that's designed very specifically to avoid everyone collapsing at the finish line from exercise-associated collapse. So what are other features of the history that would make you more worrisome? If you collapse while you're exerting yourself, that's a red flag. If you have associated chest pain or palpitations with it while you collapse, then that's a red flag. If you have a family history of cardiovascular disease, particularly unexplained sudden death or other cardiomyopathies or channelopathies or some kind of apathy, then that's a risk factor and that should be taken seriously. Other things in the history that maybe should make you not think so seriously, meaning orthostatic symptoms. So this is a common referral, a young competitive athlete who gets the swoon because they stood up too fast. Not related to exertion, but they nearly passed out when they stood up too fast. Well, unfortunately or fortunately, that piece of cardiovascular adaptation that makes you a good athlete, i.e., a very compliant heart that can handle large increases in volume with minimal changes in pressure so you can create large stroke volumes and cardiac output to run and be competitive or cycle and be competitive. So what makes you a good athlete makes you more prone to orthostatic symptoms. That's not POTS. That's not inappropriate sinus tachycardia. That's simple physiology, and we shouldn't overreact to that. The other thing we see not uncommonly is something called the athlete swoon. So this was an interesting phenomenon with the phrase coined by Dr. Paul Thompson, who I consider the godfather of modern sports cardiology, where it's that athlete who only seems to look woozy and dizzy as they're crossing the finish line. So they're doing great the whole race, and it's always in a race, it seems like. They get within a few yards, a few 100 yards of the finish line. They start to kick that in towards the end, and then they sort of swoon across the finish line and then collapse right after it. So this is, partly exercise-associated collapse, but they're swooning across the finish line. That's probably benign. You should make sure it's not benign because they are feeling sort of bad while they're exercising. But the interesting part about this is that we really don't find any pathology associated with this. And it only seems to happen in races. You ask them and it never seems to happen when they're training sessions. For whatever reason, them pushing the hard at the end of the race just makes them feel poorly, because we all feel poorly if we push that proverbial red line too far. You get nauseous and lightheaded.
Very interesting. Yeah, I have seen examples of that too. So in the subset of these athletes who might have one of these red flags, say exertional symptoms, can you just briefly go through like the sequence of testing you may consider to fully exclude a structural problem?
So yeah, you're going to want to exclude some structural problem or electrical problem. That's the other thing that would be a common cause that isn't going to show up on an echo, for instance. But you're going to start with an ECG looking for things like, WPW or pre-excitation. You're going to look for long QT, anything that would set you off on ARVC. You're going to get an echo to look for structural heart disease. And then it's going to kind of diverge from there on what your pretest probability is. If you find something abnormal looking on an echo, and you need to make sure what you're looking at isn't just athletic remodeling and you don't go down the diagnostic treat pathway. But if something looks really concerning, then a cardiac MRI is going to be potentially of high yield here to make sure you're not missing something on the echo or something small that isn't of more consequence when you get a better look and a better imaging study. Coronary CT angiogram, if the history is consistent with anomalous coronaries, which can be notoriously unpredictable in terms of their symptoms and often associated with chest pain, but notoriously unpredictable. And then any electrical studies. So that could be an ILR if you were concerned about recurrent symptoms. And an exercise stress test ought to be high on your list of things you're going to do, because some things may only pop out on the stress test, looking for things like QT prolongation is inappropriate or inappropriate long in recovery, or whether they have PVCs induced suggestive of cardiopulmonary or catecholaminergic polymorphic VT. So I'm going to always start with an ECG, an echo, and probably almost always some form of stress. I'm not looking for ischemic heart disease in most of these patients, so they usually don't require imaging. They usually require ECGs and trying to reproduce their symptoms.
So Simon, you see teenagers who present with some of the lightheadedness and other syndromes. Is your experience been similar in the younger patients who are maybe middle school or high school age in terms of likelihood of structural problems and how you would go about approach to diagnostic testing?
Yeah, sometimes it can be even more challenging in younger athletes just because chest pain is just such a common complaint. And so, like Mike was saying, I think history is really where you have to start. You really have to get a very clear sense of when is this happening? How often is it happening? Is it associated with peak exertion? Is it happening at rest and exertion? Some of those red flags that Mike talked about, those are the things that you really have to try to get. And I will say that even though it is relatively common in pediatric patients, you do sort of get a flavor of this sort of idiopathic chest pain or benign chest pain. And so when there is a story that pops up that's a little atypical or doesn't quite sound like the other cases that you've heard, those are the times where we do go for testing. And on echo, we very specifically look for anomalous coronary artery origins, or any evidence or suggestion of hypertrophic cardiomyopathy or just atypical or asymmetric left ventricular hypertrophy. And so those are definitely kind of a similar approach. And I think we just have to keep, in pediatrics anyway, we just try to emphasize the history, like Mike is saying, because one of the most common things that we get in our general pediatric cardiology clinics is chest pain.
One thing I wanted to come back and emphasize that I think is important for the cardiologist to start recognizing more is that pulmonary and respiratory symptoms can often significantly overlap with concerning cardiac symptoms. Things like exercise-induced bronchoconstriction, exercise-induced laryngeal obstruction, dysfunctional breathing are all very common in young athletes, more common than true underlying cardiac pathology. But it's something that we as cardiologists, unfortunately, have often ignored or not been taking the next step to refer on to pulmonary or speech pathology to investigate these further as causes of their symptoms.
Simon, you briefly touched on coronary anomalies and chest pain in the athlete. I just want to kind of clarify, like, what in the history might prompt you to consider doing either an echo or even a CT angiogram in a young athlete because of your clinical suspicion for an anomaly versus the more benign causes?
Yeah, so definitely exertional syncope, and not sort of that post-exertional syncope or the athlete swoon like Mike was talking about, but really, when you're competing very high intense activity and you're kicking it up to that next gear, and then all of a sudden you get this concerning history of chest pain or syncope. Those are the kinds of patients that we're typically wondering, is there something else going on? Patients who have family history of cardiomyopathy or just my uncle passed away when they were 25. They were in the military, and we don't really know exactly why, but I think they were marching, something concerning in that history. Those are the times we go for echocardiography. And one of the advantages from our standpoint, from pediatric standpoint, is that typically we have very excellent echocardiographic windows, and I would say the majority of time we can evaluate the coronary origins very well by echo. And let's say it's an anomalous right coronary from the left sinus, and you have a patient who may or may not have significant symptoms, or maybe is asymptomatic and it was incidentally diagnosed. Then I think that's when we start to talk about advanced imaging. So what we do, we always get a CT coronary angiography just to look to see some of the risk factors. Is there an intramural course? How long is it? Is there any hypoplasia of that interarterial intramural section? Is it a right dominant versus a left dominant coronary system? What does that osteomorphology look like? We can do 3D rendering to try to see, does it look like a very concerning, very narrow or slit-like ostium, or is it more of a oval or round kind of ostium? And then from there, we like to do provocative ischemic testing. And so we'll either do sort of a dobutamine stress echo, or we've been working with our colleagues at OSU who have the ability to do exercise stress perfusion MRI, or nuclear studies. So we like to try to get a comprehensive evaluation.
That's helpful to know. So I guess I can summarize in our last few minutes here as we wind down. It sounds like both Mike and Simon that you're both saying that history is always going to be the key to distinguishing these everyday causes from potentially more pathologic ones, and then judicious use of imaging with an emphasis on stress testing, maybe to reproduce symptoms, and then perhaps judicious use of more advanced anatomic imaging to confirm a diagnosis. So I think that's a great template for our audience to follow. In our last couple of minutes, I did want to just touch on one other topic, Mike. I understand you're speaking this weekend at the ACC meeting, and you're going to talk a little bit about the controversy of ablation for atrial fibrillation in athletes. Can you just, in our last couple of minutes, kind of touch on what is the extent of atrial arrhythmias in both recreational and competitive athletes, number one, and then number two, how does the clinical presentation differ from the everyday AFib that all of us see as almost a pandemic in adult cardiology?
Sure. So, AFib in athletes has been controversial for a little while, mostly because it was the question initially of, do athletes have a higher incidence of atrial fibrillation? And I think that now we're coming to the conclusion that lifelong endurance athletes have some elevated incidence of atrial fibrillation, maybe anywhere from 2 to 5 times the incidence of AFib. It doesn't mean that all those endurance athletes are going to get AFib, far from it. What constitutes long-term endurance exercise? That we don't know. Is that 1 marathon a year for 20 years? Is that 4 marathons a year for 20 years? It's going to be probably something more susceptible and something more genetic predisposition on top of adding these to it. The good news is most of them, thankfully, are low risk for thromboembolic events. So that takes part of that discussion about anticoagulation away from you in terms of whether you're going to recommend the cyclist with a CHA2DS2-VASc of 0 has to be on DOAC or warfarin. But then it's a matter of what to do with it. Some of them are symptomatic with exercise. A lot of them are more symptomatic at rest than they are with exercise. But a lot of them don't want it there. They don't respond well to medical therapy. They don't like beta blockers. They don't like calcium channel blockers. We get hesitant about antiarrhythmics, particularly the 1Cs, without concomitant AV nodal blocking agents in these athletes. In addition, I get nervous about antiarrhythmics when you send out an athlete going to do a long endurance event and their potassium, their magnesium is a little off, their core temperature is off, their volume status is a little off. And how can you potentially increase their risk of a proarrhythmic event from your antiarrhythmic event? So then that brings up, well, then should these all go for ablation, right? We like ablations. They seem to be pretty successful, but what does success mean for an athlete for AFib ablation? Athletes want it gone, and they want a high probability that's going to be gone. But if you start looking at some of the data, even in athletes, which is more limited, they still often require more than one ablation. A lot of them still don't get completely off medications. And probably that the most controversial and hardest to deal with is when you look at the data for even athletes that undergo ablation, on average, their resting heart rate is about 10 to 15 beats per minute higher after their ablation than it was before their ablation. And those of you that take care of athletes know that these athletes wear their resting heart rate like a badge of honor. My resting heart rate is so-and-so. So that is the largest complaint I get post-ablation from an athlete is my resting heart rate's higher. So there's still a lot to be done to understanding really the success and what defining success means in ablating an athlete, in addition to what improvement in their quality of life has been. Some of the data now being published shows that, a lot of the general population has improvement in their quality of life, but I'm not so sure that quality of life questionnaire in the general population is the same quality of life questionnaire that an athlete experiencing AFib would mark as being important to them.
Well, that's an interesting perspective because I do agree that it's an extremely unique group of patients, very different than what we are used to dealing with in adult cardiology in general. I wish we had some more time to address a few other topics, but I think we've covered a lot in 30 minutes. I know we're going to continue to have sports cardiology topics at our Ohio meetings. There's a lot of information that will keep coming out, and we'll do our best to get that to our audience. I'd really like to thank you both for taking the time to chat with us today and help spread some knowledge about sports cardiology.
Great. Thanks for having me.
Yep. Thanks for having me.
Thank you for joining today's podcast. For more information about the speakers or the topics, please go to ohioacc.org.